Thank you for being here today, and all our audience out there in Brazil. Thank you very much for being present in this session. It is a great honor and privilege to have such important speakers in our session today. And we're going to discuss multidisciplinary care during labor and delivery. Our speakers are Martina Kroning. She's a nurse and a midwife, and she has been working at the National Maternity Hospital over the last 23 years. She's currently the clinical coordinator of the labor ward of the National Maternity Hospital. The National Maternity Hospital, for the Brazilian audience, is one of the largest maternities in Ireland, and it has approximately 8,000 deliveries per year. It is a high-risk tertiary maternity, and its current C-section rate is approximately 30%, 30%. Our first speaker will be Martina. Then we will have Dr. Mike Robson, who is an obstetrician and gynecologist, and he has been working at the National Maternity Hospital for the last 15 years. Dr. Mike Robson was a director of the National Maternity Hospital during 7 years. He is famous here in Brazil. Everybody knows him by his classification, the Robson classification, or the 10 groups classification, which he created in 2001. In 2014, the World Health Organization recommended the use of this classification to monitor C-section rates worldwide. Then we will have Dr. Ana Pilar Beltrán, who is a medical doctor with a PhD in public health, and she has been working at the World Health Organization over the last 22 years. She's currently a medical officer at the Department of Sexual and Reproductive Health and Research, and she's the focal point for C-sections at the World Health Organization. She is involved in several international projects to improve the quality of care during labor and delivery and to safely reduce C-sections. And our last speaker will be Dr. Mário Makoto Kondo, who is an obstetrician and a gynecologist with a PhD in obstetrics. He is a professor at the Department of Obstetrics at the University of São Paulo in São Paulo, Brazil. And he is also the coordinator of the obstetrics department of Hospital e Maternidade Santa Joana in São Paulo. The topic of our conference today will be multidisciplinary management of labor and delivery. Here in Brazil, we have a very medical-centered model of care during labor and delivery, where most of the care is provided exclusively by doctors, by obstetricians, gynecologists. In other parts of the world, there are several other models of care during labor and delivery, and there is more involvement of midwives, nurses than in our country. So we will hear about a different model of care from our context, which is used in Ireland and also in several other countries in the world, in the UK in general and in other countries of the world. We will hear from Martina the experience of providing this multidisciplinary care during labor and delivery from the field, from the trenches. She's worked as a midwife and nurse for many years, and she has this experience of real life. How is it to work with doctors and women in labor in her setting, which is the National Maternity Hospital? Then we will have the perspective of a physician who works in this model of care. And finally, we'll have a broad view, an international view of a collaborative model of care in the world and what are the elements that are important in this model of care for it to work. And finally, we will hear from Dr. Mário Makoto the experience of the Santa Joana Maternity Hospital in starting to provide a different model of care for our patients here in São Paulo, Brazil. So now to you, Martina, for your presentation. Thank you. You have 20 minutes.
Thank you. Thank you. Thank you very much for asking me to speak today. It's a real honour. Having met you all last November, I was hoping that we'd have this conversation face to face, but the pandemic in the world has changed all of that. So thank you for asking me. This presentation I'm going to give today is purely from my perspective of being a labour ward manager, working in a labour ward for the last 23 years. All of my experience is care and labour. Even to date, that's what I do. I'm present on the labour ward every day. So this is just from my perspective. When we talk about multidisciplinary intrapartum care, what that means is that's a model of care whereby care is provided by a team who comprises of an obstetrician, there's anaesthetists, there's support staff. Now, support staff can be your laboratory, then can be your catering, your representatives from health and safety, your representatives from your education department. So all the many different departments within the hospital that can affect care and labour. Also the midwife who provides that care, but it's very important to note that the mother or the woman is centre to all of this care that is provided. When you talk about multidisciplinary intrapartum care, there must be agreement on 3 key principles. Those principles are: safety is paramount, everything must be made simple, and you must have consistency of caregiver and the type of care that is provided. So to ensure that these key principles are applied in care and labour, there are a number of different things that need to be considered. You've got to consider the structure of your organisation, the type of care and labour that's provided, and also how you conduct audit. So I'm going to speak about these individually. When you talk about the organisational structure, you talk about one named consultant with overall responsibility for the care that's provided, the type of clinical care guidelines that direct the care that the midwives on the ground will give, and the person who is ultimately in charge of providing that care and labour, and that has got to be a midwife manager, and I'll speak about that. So when you talk about the organisational structure and you talk about a named consultant, there's got to be commitment that on any given moment in the labour ward that there is one named consultant with the overall responsibility for care that's being given. So that consultant has got to have a presence on the labour ward. So every day you go to a labour ward, in our labour ward, one of the most important questions that will be asked is what consultant is responsible for today, who is the consultant on call today, and that's a named person, and he or she will do a round on the labour ward twice a day. So, you know, he's very much part of the team, the midwives, the anaesthetists, so everybody knows who he or she is. He does a round of the labour ward, bedside round, every morning and every evening at the end of the day. So he's very familiar with the skill or with the mix of complexity of patients or women that are on the labour ward, and that's very, very important. And he's called out of hours, he's available to attend any delivery should the need arise. The care that has been given, you've got to provide clinical care guidelines which are agreed and followed by all midwifery and obstetric staff. And these guidelines serve to support the standardisation of the care that's provided and encourage best clinical practice. Now, what that means is that irrespective of the type of patient, whether they're public, whether they're private, whether they're under the care, or whether they attend a consultant privately, every single woman is cared for in exactly the same way. So the midwife in the room isn't confused. She knows the type of care that is expected of her to provide, irrespective of whether the woman is Dr. Robson's patient, Dr. Bertrand's patient. This lady is cared for in exactly the same way, and that care is guided by the guidelines that are provided by the hospital. So you've got to put a lot of work from a multidisciplinary perspective. There's got to be input from anesthetics, there's got to be input from health and safety, there's got to be input from infection control, so that an agreement can be given overall on what kind of care we wish to provide to our patients, guided by our guidelines. It's very important for me to speak about the midwife manager. So the midwife manager in the labour ward is openly acknowledged as having a key role in running the labour ward. She's ultimately in charge. She has overall responsibility for managing the care of care in labour, and she too is responsible for multidisciplinary discussion between the consultant, the registrar, all of the other teams that need to be communicated with, and all critical decisions are communicated with her. Now, she doesn't make all the decisions, but she is aware of all decisions that are made. So you have to imagine this role. This midwife is often described as, you know, the leader of the ship. She wears a different colour. She's clearly identifiable on a daily basis. So you walk onto the labour ward and you know exactly who the midwife manager is. And it makes sense, actually, that the person in charge of the labour ward is a midwife, because midwives are with the women in labour. So of course it should be a midwife who is responsible for taking charge. Now, this midwife has no other job, and that's very important. She doesn't attend meetings off the unit. Her only responsibility on a daily basis is actually managing care in labour. So she has a key role to play in communication with the non-consultant and the consultant obstetricians, because she will often be the one who can preempt problems that may occur. So if the decision is made to take a lady to theatre, she might be aware that there's another lady that there may be a problem with down the road. So she may perhaps suggest, well, if you're going to theatre, you're going to be unavailable to the labour ward for a certain period of time. Maybe you should review this patient in advance of that. So she's a close working relationship with the team of doctors, the team of obstetricians, in ensuring that the care that's provided is safe. So she has eyes in every room, whereby the consultant or the non-consultant doctor may not have eyes in every room. She is aware of what's going on throughout the whole unit. And she's very expert. It's very important for us to note that she's very expert in her field. She has huge experience and has gained a huge amount of respect between the doctors, the non-consultant doctors, midwives, and even with her own midwifery colleagues. So she's a very important role to play. How we provide care in labour is very, very important when you talk about multidisciplinary approach to labour. There's got to be a commitment from the organisation that we will provide one-to-one care in labour, and there's also got to be diagnosis of labour is really, really important. An agreement on diagnosis of labour, which is a real challenge, as well as very important. When I talk about care in labour, what that means actually is if an organisation commits to providing care in labour on one-to-one care in labour, that means that personal attention is given to one woman by one midwife. So it doesn't mean that there's a group of midwives caring for a group of women. It means that one woman is providing care for one patient. So a patient arrives in and she will be introduced to her midwife. And the commitment is that this midwife will remain with this woman for the duration of her labour. As you can appreciate, that will have challenges, because from an organisational perspective, to ensure you provide one-to-one care in labour, there's got to be a commitment to having a limited length of labour. And we would say you must limit, we in our organisation commit to limiting the length of labour to 12 hours. But you cannot underestimate the value of providing one-to-one care in labour. That's one midwife caring for one woman. Like, the midwife is an absolute advocate for the woman in that situation. The woman really feels that, you know, we are taking an active part in providing care for her, protecting her, keeping her safe during her time in labour. And women don't forget that. They don't forget the person that has spent all of this time at their side for the duration of their labour. And it's a huge and really worthwhile investment when you talk about providing care in labour, is that you provide it for one-to-one care. And that means if you've got 10 rooms, means that on a daily basis you have to have 10 midwives should those rooms become occupied with, and that's a big commitment. It doesn't mean that you can assume that one woman can provide care to two women. One-to-one care means you provide one midwife to one woman. That is a challenge. We'll talk about that later, but it is a very valuable tool for care in labour to ensure that everything is safe for the mother and for everyone. It enhances communication, all of those things. And then we'll talk about diagnosis of labour. The diagnosis of labour is the single most important decision in care in labour. In our organisation, the midwife makes the diagnosis of labour. And that is an agreement that comes from the very, very top of the organisation. The master of the hospital agrees that the midwife has ownership on diagnosis of labour. So a woman is sent in our organisation, the doctors will hand over the diagnosis of labour to the midwives. They know that that's not their role. It is the role of the midwife to diagnose labour. And following on from that, you have assessing of progress. So midwife will diagnose labour, then she's also responsible for assessing progress in labour. And of course she should be the person to do that, because she's sitting with the woman in the room. She's looking at all of the other stressors. She's talking to the woman about, this is your progress. This is what we anticipate for you. This is what, when we haven't made progress, she communicates all of that back to the multidisciplinary team, and a plan for further care in labour is made. She also, on an ongoing basis, will monitor the fetus, whether that's intermittent auscultation or by continuous CTG. Any deviations from normal in either progress or in the condition of the fetus is communicated between the midwife, the manager, and the multidisciplinary team. Decisions about pain relief, decisions about requests from the mother, all of that comes from the midwife providing one-to-one care, the midwife who's made that diagnosis, the midwife who's assessing a woman's progress in labour. She's communicating all of that back with other members of the team. Now, that all sounds, in theory, that is a fantastic model, and it works really, really well. And one, I would, of course, assume that it is the best model of care for care in labour, but I might just say it is not without its challenges. There are many challenges and many elements to the challenge, from an organisational perspective, from a workforce perspective, and from a consensus. Organisationally, the commitment to provide one named consultant with overall responsibility is a really big commitment to make. You have to commit that the consultant will be available. You've got to have skilled consultants that can attend. So you've got to ensure the training of all of these consultants. But the provision, they've got to be, if you commit to providing a named consultant, they've got to be present. That means that they can have no other responsibilities anywhere else in the hospital. And that is a challenge for an organisation. It's difficult if you have a consultant that is maybe operating and they're the named consultant on the labour ward and they're operating in a theatre. They're not available to you in the labour ward. So that presents its challenges. And then the agreement that the midwife is in charge, that means that the non-consultant or the consultants are handing over that ownership on care and labour to the midwives. And we almost accept that privilege in our organisation. And I would say it's a privilege, and we have huge autonomy as midwives in the National Maternity Hospital, but that's because there is trust, and that trust has to be earned. And that's not without its challenges. We have to work together, and we have to keep working together. And, you know, we've got to earn that trust, and we've got to prove that we are worthy of having ownership on all of those elements to care in labour. The challenges to the workforce in relation to midwives, you need a lot of midwives to provide one-to-one care for women in labour. It's really difficult sometimes to commit to providing that care, because if you imagine you start a 13-hour shift and you go into a woman and you know that I am here for 13 hours, and you walk in and after half an hour you think, how am I going to sit with this lady for 13 hours? Clearly we mightn't get on, you know, she might be difficult, you just might be having a bad day. It's really challenging, that, and it's really tiring. And, you know, you have to be resilient as midwives. And the job as me as the manager of all of these midwives is, you know, how do you maintain their resilience? How do you ensure that their health and well-being? So there are challenges to that. And the challenges include ensuring the skills and the competency of the midwives. They have to be expert in our labour ward. Our midwives have a huge extended role, which includes suturing, cannulation, interpretation of CTG, all of that. And you have to have trained staff if you are providing a service that is safe and that is, you know, safe for the mother, safe for the baby. So there's a lot of work that goes into it. It's not just putting these people in place. You have to ensure that you maintain their skills on an ongoing basis. And equally, the job of the midwife manager is not a job that you can do forever. So you've got a future plan. You've got to bring your midwives who are, you know, maybe started as midwives, junior managers, senior managers, so that they get to a stage whereby they are the experts in their field and in a position to be the manager. And then I've already addressed the consultant available to tend the labour ward. That is huge challenges. These consultants have got to be available. They can't be anywhere else. They can't have other commitments when they are looking after the labour ward. So that has implications on managing their workload. Now, this is consensus. You know, we all know what it's like to be sitting around a table, an anaesthetist, an obstetrician, a midwife, all the other support staff, and how difficult it is to get agreement. Like, that is one of the greatest challenges when you talk about care and labour, is consensus. It's really hard. People have to be, all views have got to be respected. There's got to be, when you're trying to achieve consensus, there's got to be negotiation. You've got to be a really good negotiator. And sometimes you've got to be prepared to, you know, almost, there's got to be give and take. You have got to say, well, that's not the most important thing to me. This is the most important thing. And you've got to, you know, let go of some of your beliefs, so as that, you know, you can all, the goal has got to be to achieve a common goal at the end of all of your discussions. And that's very difficult. And then the commitment to manage care and labour and to avoid prolonged labour, it's very difficult. That doesn't mean that if a woman gets to 12 hours, that's it, her labour is over. We've got to have an ability to discuss, okay, well, the midwives and the obstetricians will sit around and say, okay, well, this lady looks like she may perhaps have a vaginal delivery and we have reached the prolonged labour stage. But if the woman is in agreement, we've got to agree that that is okay for her to go. But it's all about agreement, negotiation and discussion, which is difficult. We can't ignore the fact that audit has a huge part to play in care and labour, particularly for midwives, and that's about collecting data and also listening to your patient and what kind of experience they had. The midwives in our unit collect data, they're part of continuous audit, and they review the outcomes. So we think we're doing a great job, but how do we know we're doing a great job unless we look at what we're doing? We need to look at our outcomes. We've got to talk about, there's got to be a forum for discussion. You've got to have an opportunity for people to sit around as a multidisciplinary team. We have a meeting in our labour ward and we talk about cases in labour that were maybe difficult to manage, or particular cases that the individuals themselves found difficult to manage. And we would discuss in a no blame way. It's very open forum. There are midwives, there are obstetricians, there are non-consultant doctors, and they all together will sit around and discuss this case. I mean, you know, they're great discussions, so they are, and quite often, you know, sometimes they're heated, sometimes they're not, but everybody has a voice, and that's really, really, really important. But nobody walks away thinking, you know, oh, that they've been blamed for any of the outcomes. It's very much a no blame culture, and that has got to be the way for successful running of a multidisciplinary team in a labour ward. The patient experience is very important. We in our labour ward ask women to evaluate the care that they receive. We all give them the opportunity to discuss this care if they have any questions. Any of their negative issues are discussed with both the staff and the patient herself. And we also would congratulate the positive feedback. We display all of the feedback that the women give. We display it on our labour ward, and it's very much part of it. Highlights to us areas in which we can improve, and most importantly, it's how we can improve the care we give by the feedback that we receive from the women themselves. I just finished by saying there are numerous benefits to effective multidisciplinary care from a midwife's perspective. The job satisfaction is huge when midwives are given autonomy in labour. You become an expert in your field. The staff retention is really good because you feel valued. When you're part of a team, part of an effective team, you feel valued and you feel happy. And all of these have an impact on the care that the woman receives, the patient receives, who is ultimately at the centre of multidisciplinary care. Thank you all for listening.
Thank you very much, Martina. It was a great presentation. Later, after all the presentations, we'll make some comments and questions about your experience at the National Maternity Hospital. And now to Dr. Mike Robson, from the perspective of the obstetrician and gynecologist working in this model of care.
Thank you, and I'm delighted to be part of this session, having listened to Martina, when you listen to my talk as well, you'll realize how much we've got in common, and that's an important reflection itself. Today, I'm going to talk about multidisciplinary intrapartum care and team working, if you like, but we must remember that's not an end in itself. The end is far more important than that, and it's how the patient gets on and how the staff get on and looking after everybody. I'm going to give you the perspective, if you like, of the obstetrician, but a lot of these issues that I bring up are similar for both obstetricians and all the staff that actually work on the delivery ward. But even before that, I think as a group, we have to think, what are we trying to achieve? Ideally in labour wards, you'll have a little sign over the entrance saying exactly what you want to achieve. And sometimes it's not certain what we are trying to achieve. We're just a bunch of individuals just trying to do the best way we can. I think, for myself at least, the overriding aims are safety and quality, and safety goes without saying. Quality is a little bit different. There's the nuances there which may vary between different countries, between different groups of patients and staff, and can be measured in different ways. But safety itself is becoming the crucial issue. And the best way I think we can achieve that is through simplicity and consistency. And if you're talking about any team working together, the simplicity part and the consistency part is so important to enable that to happen. The patient needs to be at the center. I know Martina's emphasized it, and I would like to emphasize it as well. Everything that we're doing on the labor and delivery ward has to bear in mind that the patient has to benefit from it. And if the patient doesn't benefit from it, then we have to reassess what purpose it has in the care that we're trying to provide. But how do we achieve this in a multidisciplinary environment on the labor and delivery ward? I think we have to look at who is involved and who the different disciplines or what they represent. And the very obvious ones are the midwife. I think it's very appropriate that the midwife comes first, because she is, in my view at least, and as an obstetrician's view, with an interest on the labor and delivery, the most important person on the labor ward. The obstetrician, obviously, the neonatologist and anaesthetist, and they're probably the key players. But it's very easy to forget all the other members of staff. And I think we do that at our own risk. We've got to realize in a true team, there are no people in that team that are more important than others. And I would also suggest to you the support staff now in a labor and delivery ward is increasing all the time. These are the people that supply, that clean, that check that everything is working, the infection control team, and more IT team, information technology are becoming a bigger and bigger part of the team. The more we go to electronic records, and most people, organizations are trying to think that way, but obviously a lot of organizations aren't able to at the moment. But those of us that do realize how important they have become. And all the sophisticated equipment that we use now in order to provide good care for the mother and baby and the family indeed are very important. So medical engineering. And it's very easy sometimes to forget support staff, or just treat them or manage them in a way that maybe not deliberate, but obviously doesn't give them the credit, the open credit, the acknowledgement that they deserve and that we depend upon. In addition to be able to provide good teamwork, and again, it's not directly dealing with the main individuals involved, but more to do with how they're provided with everything that they can do that, are the resources and infrastructure. You do need resources to acquire all the equipment that you need. You do need the infrastructure. You need the rooms to provide the care. But interestingly, again, you know, too much resource can be as much of a problem as too little resource. And the same with the infrastructure. If you have a labor and delivery room with 30 rooms, when actually you may only need 10 rooms or 15 rooms or whatever, that provides additional issues that come up, which may prevent or make it more difficult to working as a team. And remember, I emphasized again that the patient, if you like, not so much a member of the team, but is right in the middle of the care provided. Once you have a lot of rooms, there are geographical issues in able to look after the patients in the best way. And even if you like the layout of the labor ward, certainly maybe in relation to the theatres, the neonatal unit, and other support structures around. So they are very important to consider how they would work, but with the emphasis of enabling teamwork to take part in the best way possible. We have all these different providers. They all share care on the labor ward, but they all need to be recognized, acknowledged, and given what they need to provide that care. But having said that, and bringing everybody together, one person has to be responsible for the labor ward. And for practical reasons, in most labor wards, it is an obstetrician. And there are good reasons why it has to be such. Now, at this level, we're talking about an obstetrician who's got responsibility for everything going on in the labor ward. That doesn't mean to say that they haven't got their own responsibilities, for example, on the day they're on call or other issues, or looking after their own patients. But you do need somebody that is in charge of the whole organization, the whole labor ward. That has to be recognized, and it has to be recognized that although on the one hand you can have a very democratic, if you like, way of discussing things, of organizing things, you can't get away from the fact that ultimately somebody has to make a decision, take responsibility, and runs it in a certain way and makes decisions about whatever aspect of care it is, of the different ones that I've mentioned up to now. Why is it an obstetrician? Well, in theory, you could have either a midwife or a anaesthetist or a neonatologist in charge, but it just makes more sense, I think, and everybody would agree with this, that it has to be an obstetrician. But that obstetrician, while being in charge, and the other specialties have to recognize that, has to have good working relationships with the other people, making sure that everybody is contributing in the best way that they can. And when we get down to organization, as Martina has alluded to, there has to be an overall policy or an agreement for the key decisions in labor and delivery. And they have to ultimately be agreed on a multidisciplinary basis. And I'll come back to that in a moment. But more than that, and again, this was brought up earlier by Martina, there has to be agreement then, once those decisions and the philosophy, if you like, guidelines, whatever you want to call them, protocols, processes, there has to be agreement about whose responsibility each of those decisions rest with. And again, I will come back to that later on in more detail. Martina gave the example, and it's a very good example of the diagnosis of labor. But let's just move back to agreeing guidelines, agreeing the actual principles of care. And this term evidence-based medicine is used everywhere now. I sometimes wonder what people mean by it. It's almost possible to prove everything is right, and it's almost possible to prove that you can't prove anything is right. But in the end, it comes down to personal opinion based on some facts. And these facts, you know, are represented, I think, by competing philosophies. They could be process-driven, randomized controlled trials, or they can be outcome-driven, perinatal audit and epidemiology. And as a team, or in any multidisciplinary team, everybody has to be up to date, is maybe not the appropriate phrase to use, but at least be aware of and have an interest of knowing actually what the evidence is, in whichever form it is. Again, there are some things that are worth discussing, important principle that are worth discussing until you really agree completely on that, and somebody has to take a decision. And there are some aspects really which I feel far too much time is spent arguing about things and not being able to agree. But I think people have to be aware, in a labor and delivery unit, if you have available information, if you make that information available to everybody, we may not always agree, and there may be a difference in how you interpret it, but at least that information is there for discussion, and that will enable a decision to be made. But there's a difference between standardization of what actual processes you agree on, but in some labor and delivery wards, there isn't an agreement or an acceptance or adherence to standards, if you like, of terminology and documentation. I can't go into all of this in detail, but I think some of it will come up with the discussion. But for example, terminology, just to give an example, writing down the examination of the cervix. Some people use 50% effacement. Some people use 1 centimeter long. Some people actually say 1 to 2 centimeters dilated, as opposed to 2 centimeters dilated, be it wrong or right. There's some kind of discipline to using the same terminology, and that should be issues which they shouldn't be difficult to agree. You have a discussion and we're going to say we're going to do it. They're not even pertaining to practice itself, although they could affect practice. And documentation is another example, particularly on the labor ward and labor and delivery ward. And we would have strong views on this, is that the partogram should be used as a matter of discipline. It's not necessarily the partogram to actually say that it should be 1 centimeter an hour, 2 centimeter an hour, the supposed action lines that people refer to. The partogram is just a, certainly if designed in an appropriate way, a succinct way, a visually easy way to show what's happening in the labor ward. But there has to be an agreement by everybody that we are going to do it this way. Whatever the care, and I'll come back to that in a moment, processes or guidelines, just agreement to use the document, use the partogram in a standard way to make sure that it's filled out appropriately, and to realize that the fact that partograms don't get filled out appropriately or not easy to review, or all the information isn't there, may not affect that individual woman, but it does say something about the discipline of a unit and the agreement or the importance that is placed on standardizing the monitoring of care. I think there are some standardizations of philosophy which are also important. The very fact that acceptance of the difference and the importance between a nulliparous woman, a multiparous woman with or without a scar, the difference between spontaneous and induced labor, and the difference between single cephalic, single breech, and twins, and the degree of team working that can be shown is that people accept that, and they have a disciplined approach, and they know exactly when they're looking after patients, which ones what type of woman, what's their previous history that they're looking after. Again, on some delivery units, they all merge into one, and nobody has a discipline of differentiating between a nullip and a multip, or spontaneous and induced labor. The key decisions in labor and delivery, the key processes, if you like, that you have to agree on if you are going to try and develop teamwork are, and they're not only the criteria for diagnosis of labor, but also who makes the diagnosis, are the diagnosis of labor, the artificial rupture of membranes, when do you do that and what the indications are, the assessment of progress, whether it should differ between first-time mothers and second-time mothers, the decision and when to give acceleration of labor with oxytocin, the way you monitor the baby, even delivery, who does the delivery and what way the delivery is involved. And Martina's already talked about consultant involvement, which is absolutely crucial. And when you agree on what that consultant involvement, that has to be carried out. Which deliveries the consultant is expected to be there for or not. And Martina alluded to a very important point. Yes, in our hospital, we do have public and private patients, but that doesn't get in the way of teamwork and making sure that those same principles are adhered to. So the consultant involvement and the consultant on call would be expected, say, for example, to be present at a cesarean section at full dilatation, or even the decision to make to do a cesarean section at full dilatation, should be there for multiple pregnancy deliveries, twin deliveries, should be there for a breech delivery, should be around for emergencies like shoulder dystocia, But that brings up another issue about multidisciplinary teamwork, which I think is important to remember. I think we have to acknowledge that an experienced consultant, I don't really know of any labor and delivery ward in the world that insists that the experienced consultant is always sitting in the labor ward, i.e. within 30 seconds access of any room. I don't think there's any labor ward in the world that has that, well, not only a resource, but also has that discipline to ensure that it's carried out. So that means for something like shoulder dystocia, it is very often that the experienced obstetrician is not present when that occurs. And that's why you have to work as a true team. You have to recognize that. You have to give the appropriate responsibilities to the people that will be there. And the person that is always there is the midwife. But then again, within a midwifery responsibility, if you like, of what they're able to do, they apparently, I say apparently, meaning that, you know, that's what's usually accepted, that is limited to the normal. But in true multidisciplinary working, there has to be overlap as well as a discipline. We may discuss some of these issues in more detail later. The other aspect of organization is consultant obstetricians who cannot agree a common pathway, a policy on the important decision taking place on the labor ward, represent the biggest impediment to improving the standard of care on the delivery ward, and that also has to be agreed. So consultant obstetricians are trained in such a way that they are thinking individually rather than thinking as a group. And it's very difficult for very highly trained individuals to actually think of a group and come to a common agreement. Ultimately, all responsibility for outcome and decisions within agreed practice rests with a consultant obstetrician responsible for the labor ward. That's really important, that if anything happens, and it happens within the agreed framework, it is the responsibility of the consultant obstetrician responsible for the labor ward. It is not the responsibility of the individuals that make the decisions, providing it's within an agreed framework. And on the labor ward itself, one person has to be in charge of the labor ward at any one time. And for practical reasons, that person has to be a midwife, and obstetricians need to recognize that and understand the benefits. I don't think from my experience that it could be any way different. So at any one point in time, the midwife in charge of the labor ward is the person that makes all the decisions. Perinatal audit, just like we share everything, it's very important that there's a multidisciplinary commitment to all the collection of events and outcomes and complications, and a multidisciplinary commitment to the study, interpretation, and dissemination of clinical results, leading to the clinical improvement in practice and care provided to the woman and baby. So often, on many labor wards, interestingly, the midwives seem to collect all the information, but are less involved in analyzing information and publishing information, while the obstetricians aren't involved actually recording information, but are more interested, if you like, for professional reasons, to look at the outcomes and publish on it. What I'm trying to say, there has to be a joint commitment not only to the collection of events, but also to the study, interpretation, and dissemination of results, leading to the clinical improvement. What are the challenges? There are a lot of challenges, and I think Martina has discussed many of them. I picked on one where you have a unit where there is agreement on what, if you like, our birth plan is for the women that are coming in, and we do that out of total respect and trying to make sure that we adhere to what's safest, not only for an individual woman, but as for the group of women as well. But what has happened for different reasons nowadays is the development of birth plans and choice. And choice is an interesting word. And I've gone through some of the definitions on that. It's a logical selection from a number of alternatives based on information that is available. We would hope that any logical selection that a woman would choose would be the same as ours, providing the information is available. Selecting something that is considered desirable or proper, despite possibly illogical, maybe something like that would be no continuous monitoring in a patient, in a woman that has had a previous cesarean section. They would like something, but it's a little bit illogical, or at least there are risks of doing it. And also sometimes choice is not always something that you desire, but rejecting something that you do not want. And often selecting a cesarean section opposed to going through delivery, it's not that somebody wants a cesarean section, it's a reflection on labor and delivery, and that has to be recognized, and then it comes back to dealing and improving the facilities for labor and delivery. I think meaningful and successful multidisciplinary intrapartum care does not occur by accident, but only as a result of a common goal, a disciplined approach, and the willingness to lose a small portion of clinical independence for the greater good of all our patients. I would say it's difficult to get to a situation where you are really providing meaning and successful intrapartum care, but I would also say it's even more difficult to maintain it. Thank you for listening.
I want to thank first Santa Joana and the organizers for inviting me to take part of this session. And I want also to thank Martina and Mike for their fantastic presentations. I will talk about collaborative models of care from a more general global perspective. So globally, facility-based childbirth has been identified as a key strategy to improve the safety of intrapartum care, particularly in low and middle income countries. Over the last decades, we have succeeded in promoting this strategy, and we have increased the number of women giving birth in facilities. This is actually very important because 2/3 of the maternal deaths and nearly 1/3 of the stillbirths and neonatal deaths globally occur around the time of birth. So getting the women to the facilities is fantastic, but we need to do more. We need to ensure timely access, and we need to make sure that when they come, they get the best possible care. So what's in the facility? What's next? What is the best? So we have to acknowledge that medicine has become increasingly complex these days, and our work has become more and more complex. It is not about technical skills anymore. And in the words of Atul Gawande, a renowned American surgeon and communicator, we can read, "You enter the profession convinced that it's all a matter of canny diagnosis, technical skills, and some ability to emphasize with patients, to soon discover that you have to deal with resources, the system, relationships with colleagues and patients, and their own shortcomings and limits." So just to show you the complexity of some of the aspects that we have to face, let me share with you a graph showing all the factors that affect the use of cesarean section. The first layer is represented by the Robson classification and contains the obstetrical factors, the more direct clinical factors. The following layer has to do with the factors regarding women, families, and communities, and includes the choices that Mike was talking about, fear and anxiety, the previous birth experience, etc., etc. The next layer is about the factors related to health professionals. We can recognize here many beliefs about what women can or cannot do, dysfunctional teamwork, fear of blame, etc. For the last layer, where we can see the organization, system, and facility factors. And here we have factors from the role of hospitals, logistics, financial structures, etc. So in the end, when it comes to our specific day in the hospital, we really have an earthquake, which is almost impossible to control. But going back to what and how we do in the facility, the question is, what is the model of care that optimizes outcomes? Unfortunately, there is no universal answer for this question and depends on many factors, including many that Tina and Mike have mentioned. And it depends on also the type of hospital or facility or where this facility is located. In many countries, particularly where obstetricians are not available, care for labor and birth is provided by nurses and midwives. There are countries where obstetricians are available, but still midwives provide the main part of the care. And the Northern European countries are some of these specific countries. And then there is also another type of country in which maternity care is just provided by obstetricians. The truth is that midwives are the major providers of care and childbirth in many countries. And midwifery services are underpinned by a concept of normality of childbirth in most of these countries. And for low-risk women or women without complications, midwife-led continuous care has been recommended and is considered cost-effective. Benefits that have been observed, among others, are the increased likelihood of giving birth vaginally, lower intervention rate, including epidural anesthesia or instrumental vaginal delivery, and a shorter duration of labor. However, 20% of the low-risk women may develop intrapartum complications. So we need, other interventions might be needed, and taking care of those women may require somebody else than a midwife. So to ensure safety for women and newborns, collaborative models of care are gaining acceptance. And in this slide, I just have three among others, midwife models of care. The first one is the on-site midwifery-led birth units. These are midwife-led units that are independent, but which are side by side with higher levels of care, of obstetric care. They have been introduced in some countries, and this arrangement is particularly interesting where referrals do not function correctly and to avoid unreasonable burden of work on facilities. The second one, the collaborative midwife obstetrician model of care, which is called in the United States the laborist model, and I think is the one Tina was referring to with the consultant, is a model based on care provided primarily by midwives, but with the 24-hour backup of an obstetrician who provides coverage without any other competing clinical duties. In other words, the obstetrician is there dedicated to and ready to attend any call from the midwife who may be asking for help in case of any complications. The third example is the caseload midwifery care, which is a midwifery-led continuity of care model that guarantees one-to-one continuity of care by a single midwife throughout pregnancy, childbirth, and the postpartum period, with backup provided by a partner midwife and obviously in good collaboration with other professionals. This way, caseload care is defined and organized varying between countries depending on the specific maternity care system in the country, but it's gaining acceptance in many countries such as the United Kingdom, Denmark, Sweden, Australia, or New Zealand. And as we've said before, these models and others have to be tailored according to the characteristics of the health system and availability of healthcare providers. But what all these models have in common is the multidisciplinary approach to pregnancy and childbirth, point that has been also emphasized by Tina and Mike. For optimal results, including satisfaction and a positive birth experience for women, we actually need teamwork. And if we were to distill in a laboratory effective teamwork, there will be some important features that we would need to consider. This would be, and these are not an exclusive, totally inclusive list, but they would be collaboration, communication, and effective training. And I would like just to reflect a few minutes in those features. So let's start with collaboration. Collaboration, according to the definition in healthcare, is defined as healthcare professionals assuming complementary roles and cooperatively working together, sharing responsibility for problem solving, and making decisions to formulate and carry out plans for patient care. Collaboration is based on respect and recognition of the importance of everybody's tasks. And sincerely, we can't overstate the importance of this. Let me tell you a story that some of you may know. It's called the story of the President of the US, Kennedy, and the janitor. The janitor is a person whose job is to take care and cleaning of a building, such as school or apartment building. So the story goes like this. President Kennedy was visiting NASA headquarters for the first time in 1961. These were the times where US made a case of national pride to be the first country to send a man to the moon. While touring the facility, he introduced himself to a janitor who was mopping the floor and asked him what he was doing at NASA. The janitor didn't say, "I clean." No, he responded, "I'm helping to put a man in the moon." The janitor actually was working in an organization that had invested in a vision for everybody. He was part of a team and he felt his work has a purpose in collaboration with others. This is the point. If we feel part of the team, no matter how large or small our role is, we are contributing, in the case of the labor room, to optimizing women's labor and birth outcomes. So what are the essential ingredients of collaboration? We could actually learn from other competitive sports. So with this information, what this article tells us are 5 ingredients essential for a successful teamwork. And I'll just quickly go through them. First, role clarity. Each member is supposed to execute a unique role that is important for the achievements. It's an individual contribution should be valued, yet the focus must be in the team success. Trust and confidence is the second essential ingredient. Members must be confident in their own abilities to develop team trust. Third, the ability of overcome adversity. Challenge require every member to remain committed to the collective goals despite setbacks. Fourth, the ability to overcome personal differences. We have to work together even if we don't get along. And fifth, collective leadership, a philosophy that takes pressure off any one individual and disperses it throughout the group. The second essential ingredient that we mentioned was communication. Communication, not only between the healthcare providers and the women, but also between the healthcare providers. Lack of communication or substandard communication results in adverse outcomes and insatisfaction. Communication has 2 levels, the content, but also the relational level. And this is very important, as we'll see. So how do we communicate? There is a part that is verbal communication, that it occurs through the use of language, either both written or oral, and which depends on us precise syntactic or grammatical rules. Then there is the non-verbal communication that instead take place without the use of words, but through other channels like facial expression, looks, gestures, postures, etc. And then is the paraverbal communication, the tone, the volume that we use, the rhythm, the pauses that we use. And interestingly, studies have shown that 93% of the communication goes through the body language, attitude, and tone, leaving only 7% for the actual meaning of the words that we say. And this is why Paul Watzwick, which is the Austrian psychologist and father of the theory of human communication, says you cannot communicate. And this is important because even if we're not saying anything, we are communicating through other means in the labor world. Communication is so essential that is one of the 6 core values for all health and social staff introduced by the NHS in the UK in 2012, with the objective to ensure that patients are looked after with care and compassion by competent health workers who communicate well, there to make changes and improve care, and can commit to delivering this all day, every day. And just to finish, the third ingredient is effective training. Effective training, as Tina mentioned, is not easy. Preparing healthcare providers to manage relatively rare life-threatening emergency situations is a challenge. Training enables staff to rehearse for some events and is recommended in multiple reports and guidelines. But despite training being axiomatic these days, not all the training is clinically effective. Nowadays, the principles for effective training are they have to be local, unit-based, multi-professional, high-fidelity simulation models and practice-based tools, and continuous. And in fact, effective training is likely to be more about training teams to use local practice-based tools like boxes or checklists and learning in local communities of practice than just transferring new knowledge. And I just want to show you this, very visual video that I find very interesting. And it's just a few seconds. Which to me shows extraordinarily well, or depicts very well, an example of good collaboration, communication, and training. So I want to leave you with this quote from Darwin that he says, "It is the long history of humankind and animal kind too. Those who learn to collaborate and improvise most effectively have prevailed." Thank you very much.
Thank you very much, Dr. Ana Pilar. Great presentation.
Olá, boa tarde. Vamos finalizar essa mesa, que é muito interessante, falando sobre o Programa Consciência Obstétrica do Hospital e Maternidade Santa Joana. Um pouco de história. Né? A nossa espécie, Homo sapiens, há quanto tempo estamos aqui na Terra? Foi feita uma nova datação e que foi publicada em julho de 2017, quando se encontrou em Marrocos vestígios, né, comprovando que o Homo sapiens, a nossa espécie, caminha aqui na Terra há pelo menos 315 mil anos. Então, há 315 mil anos, nascemos por via vaginal. Isso é um marco muito interessante. Vamos falar agora sobre o nosso hospital, Hospital e Maternidade Santa Joana, cuja história começa em 1948, como a Casa de Saúde, até chegarmos à nossa realidade hoje. O que somos hoje? O Hospital e Maternidade Santa Joana é a maior maternidade privada do Brasil, fundada em 1948, 14.500 partos por ano, tem mais de 360 mil partos realizados desde a sua fundação, 220 leitos adultos, sendo 50 de semi-intensiva obstétrica e 10 de UTI adulto, e 130 leitos de UTI neonatal. Nós somos hoje referência em gestação e parto de alto risco, referência em medicina fetal e cirurgia fetal. Somos também pioneiros nas suítes de parto, a LDR, Labor Delivery Room. Foi a primeira maternidade que instituiu uma forma de incentivo ao parto vaginal humanizado, atendimento acolhedor e seguro para a parturiente e o recém-nascido, com presença de acompanhante, métodos não farmacológicos para alívio da dor, deambulação, analgesia. Então, isto foi introduzido há 30 anos, mas, por questões diversas, nós podemos ver que nos anos 60, 70, 80, a prevalência era aqui de partos vaginais. E, gradualmente, a partir dos anos 80, foi crescendo o número de cesáreas. Se tornou algo que, e diminuindo a incidência de partos vaginais, até chegarmos à realidade atual, que é o índice de cesáreas maior dentro não só da nossa maternidade, mas como uma realidade grande das maiores maternidades no Brasil. Com toda essa questão, no final dos anos 90, a OMS faz uma publicação falando de maternidade segura, assistência ao parto normal, um guia prático, 1996, que coloca pontos muito interessantes que iniciam uma grande discussão. A alimentação durante o trabalho de parto, a presença da doula, o respeito, movimentação, autorização, comum acordo para certos procedimentos, amniotomia, normatizando algumas questões, o próprio uso da ocitocina, posição no período expulsivo, realização de episiotomia e, principalmente, plano de parto. Onde e por quem será realizado esse parto? Onde e como o parto será realizado? São discussões que foram colocadas, então, há bastante tempo, 1996, e no Brasil, o Ministério da Saúde realizou uma publicação desse manual, Maternidade Segura, em 2001, com o título de Parto, Aborto e Puerpério, Assistência Humanizada à Mulher, Ministério da Saúde, 2001. Entramos no século XXI com mudanças, reverberando essas publicação da OMS, e nos anos 10 desse século, o parto começa a ser discutido por todos. Muita gente começou a falar do parto. Começa lá a OMS, a Organização Mundial de Saúde, falando, e as redes sociais, a grande mudança foi os movimentos sociais, Facebook, Instagram, Twitter, blogs, o Ministério Público Federal, a Agência Nacional de Saúde Suplementar, o Ministério da Saúde. Então, todos começam a falar sobre essa assistência ao parto, começam a fazer questionamentos sobre a forma de nascer e como nascer. Em 2014, o Grupo Santa Joana fez o primeiro fórum sobre consciência obstétrica, e teve a participação também de outros dois grandes hospitais, o São Luís e o Einstein. Foi colocado nessa época que havia uma demanda e uma questão chamando-se de violência obstétrica. A não comunicação, a falta de orientação da parturiente, a não anuência da parturiente sobre alguns procedimentos, a questão também do palavreado utilizado, né? A violência verbal, que é inadmissível, né? Então, nós entendemos que esta colocação como violência não seria, né? Não levaria a uma melhoria, né? Então, nós temos a visão da consciência obstétrica, quer dizer, buscar aprimorar, né? Corrigir eventuais falhas, né? Buscando que um melhor atendimento para a parturiente e o seu recém-nascido. Então, colocamos muito bem em 2014. Então, em 2014, nasce, primeiramente, um projeto de consciência obstétrica, que hoje já é um programa. Então, o que se buscou? Mudanças consistentes e seguras, pois é um problema complexo e multifatorial. Vai desde do pré-natal bem realizado, desde as orientações do pré-natal, do tipo de assistência que essa gestante, essa parturiente terá na hora do nascimento. Então, multifatorial. E foi realmente necessário uma avaliação criteriosa da realidade, de cada realidade. Num país como o nosso, continental, mesmo aqui dentro da cidade de São Paulo, nós temos diferenças enormes. Então, avaliar a realidade e o que é possível mudar dentro de cada meio, dentro de cada ambiente. Então, foi feito um planejamento cuidadoso no caminho da mudança, para não comprometer a segurança materno-fetal. O programa Consciência Obstétrica, então, hoje, ele está bem consolidado com a participação da obstetrícia, da anestesia, a neonatologia, a enfermagem, a hotelaria, a segurança. Então, se buscou que todos que atuam dentro da maternidade fossem tocados pela consciência obstétrica, né? Que saberem que nós estávamos buscando uma mudança, né? E avaliamos com isso a condição de atendimento e discutimos muito as mudanças possíveis dentro da nossa realidade. Revisão da literatura foi feita de uma forma intensa, dados da OMS, do Colégio Real de Obstetras e Ginecologia, né? O ACOG, o Colégio Americano de Obstetras e Ginecologistas, a Sociedade de Medicina Materno-Fetal, a Sociedade de Obstetrícia e Ginecologia do Canadá, o Colégio Americano de Midwives e Enfermeiras, né? O Colégio Inglês de Enfermeiras e Midwives, né? A Medline, Febrasgo, Ministério da Saúde, Conitec, recomendações da própria Agência Nacional da Saúde, Conselho Federal de Enfermagem, Conselho Regional de Enfermagem e protocolos de grandes universidades, como a Universidade de São Paulo, por exemplo. Planejamento do treinamento com instrutores médicos, enfermeiras, psicólogas, fisioterapeutas. Então, esta programação, esse projeto inicial, ele foi feito com bastante cuidado, né? Porque um estudo e realmente buscando atender a realidade hoje, nossa, né? Do que nós vivemos. Então, o programa se iniciou já em 2014, se criou esse pensamento de segurança com respeito à humanização, essa sensibilização coletiva que eu comentei, e a assistência ao parto é multiprofissional. Isto é a grande questão, seria a grande mudança, né? Ela é centrada no atendimento humanizado à paciente, segurança materno-fetal, realizada por uma equipe multiprofissional. Treinamentos foram realizados e desenvolvidos, né? das mais diversas formas. Se buscou criar um manual de consciência obstétrica para que todos que trabalham dentro do grupo soubessem, né, o que nós estamos buscando. E se hipertrofiou muito o Centro de Ensino e Desenvolvimento. Começamos uma série de treinamentos, utilizando também até atores, né, a simulação realística, colocando toda a equipe realmente em diversos cenários. Né? Foram aqui só um dia de treinamento, que são várias estações que são realizadas em cada treinamento. Né? Aqui só uma parte aqui discutindo um ponto que é crucial na assistência ao parto hoje, que é a análise, a avaliação da vitalidade fetal. Tivemos, né, no ano passado aqui, a presença aqui do Dr. Diogo Aires Campos, né, que é realmente um dos experts, né, a respeito da avaliação da cardiotocografia intraparto. Nós fizemos até um curso dirigido a toda a nossa equipe interna de médicos e enfermeiras. Normatizamos algumas questões de nomenclatura, que foi adotada as categorias da FIGO, né? Normal, suspeito e patológico. Tivemos também a honra, né, no ano passado, de receber, né, as enfermeiras práticas, né, vamos dizer assim, são senhoras, são as parteiras práticas, né, de uma região da Amazônia, que vieram conhecer, tinham uma conferência aqui dentro da cidade de São Paulo, né, um workshop, e vieram nos conhecer. Foi uma honra, porque nós conseguimos aqui interagir muito a respeito de como elas assistiam ao parto, e sempre se aprende muita coisa. E nós pudemos mostrar para elas o nosso serviço, né, e algumas questões de como nós atuamos. Então, foi realmente uma interação muito rica, da gente poder entender como se faz um parto dentro de uma tribo, numa região amazônica. E tem coisas que são muito parecidas, né? Isso que é bem interessante e bem produtivo para nós. Tivemos também a oportunidade de visitar outros serviços, outras realidades, né? Tivemos aí a honra de participar de um curso, né, na National Maternity Hospital, né, com aí o Dr. Michael Robson, né, que é conhecido de todos vocês, né, a enfermeira Martina, que é a enfermeira-chefe, né, das obstetrizes. Né? Então, foi um momento muito rico, uma semana de interação total, uma imersão total, numa outra forma também de atendimento ao parto, ao parto e ao trabalho de parto. Então, foi realmente a busca de outros modelos, né, que possam ser utilizados dentro do nosso meio. Então, foi iniciado dentro do projeto a questão da analgesia não farmacológica. Foi feito um treinamento muito grande, intenso, com toda a equipe de enfermagem. Elas foram bem envolvidas, treinadas junto com fisioterapeutas, para realmente propiciar aquelas parturientes, né, que tivessem momentos de relaxamento de uma forma tranquila para aguardar o nascimento. Né? O uso da bola de pilates, né? Aqui o banho de imersão, eu acho que um acolhimento que precisa realmente ser normatizado. Foi normatizado, foi treinado e retreinado. Então, frente a tudo isso, algumas questões muito importantes sobre a orientação e esclarecimento sobre procedimentos que serão realizados ao longo do trabalho de parto. Intervenções de acordo com a necessidade, estímulo à deambulação, colocar, né, à disposição os métodos não farmacológicos de alívio da dor, banhos, massagem, assento ativo, e analgesia farmacológica, com a walking analgesia, que são condições aqui que estão totalmente disponíveis para as parturientes dentro das maternidades do Grupo Santa Joana. Então, isto hoje é uma realidade, né? Quer dizer, são suítes de parto muito bem acolhedoras, com equipe treinada para este atendimento. Algumas questões que eram difíceis até há pouco tempo são ligadas às posições para o segundo período, o período expulsivo. Semi-sentada com apoio de pernas ou de pés, decúbito lateral, 4 apoios, cócoras, banquetas de parto. Tudo isso hoje é uma realidade e a equipe de atendimento, a equipe de saúde, enfermeiras e médicos, estão muito bem cientes, né, de como, né, atender com segurança esse período que é o mais importante, que é o período de fragilidade para o bebê. Então, nós temos que estar muito atentos. A questão da episiotomia, hoje, eu acredito que está bem elaborada dentro do grupo. Ela é seletiva para questões quando realmente necessárias. Se for um parto instrumental, um parto forte, uma situação de alteração da vitalidade fetal, exaustão materna. Quando existe possibilidade de laceração extensa, né, aquele períneo curto, que a distância entre a fúrcula vaginal e o ânus é menor que 3 centímetros, muitas vezes, e o bebê for grande, existe um risco de laceração importante. Então, nós temos que ter cuidado aqui. Quando eu tenho a distócia de ombros, muitas vezes realizar a episiotomia é importante. O contato pele a pele com RN vigoroso, hoje é muito real. Tudo isso necessitou realmente de treinamentos e normatizações, que hoje estão perfeitamente incorporadas ao atendimento obstétrico. Ligadura e corte do cordão ao cessar os batimentos. Isso hoje é muito real. Nasceu o bebê vigoroso, ele é colocado já ao contato com a mãe. Isso são coisas hoje que são realidade dentro da maternidade. Então, nós temos, 6 anos após, mais de 600 profissionais treinados, o manual de consciência já foi revisado e atualizado. Fazemos hoje, com muita tranquilidade, entrevista com os casais, né, com enfermeiros, anestesistas, obstetras, para discussão de plano de parto, daquilo que nós podemos oferecer e o que nós não podemos oferecer, de forma muito transparente. Acho que isto é o que o programa Consciência Obstétrica visa, a transparência, né, e a mostrar o porquê muitas questões não podem ser atendidas. Enfermeira obstétrica hoje realiza assistência ao parto com supervisão médica. Então, hoje, a enfermeira ela está capacitada, está treinada. Sempre é um trabalho colaborativo. Médico, enfermeira, enfermeira, médico. Eu acho que essa é a realidade hoje que nós buscamos aprimorar cada vez mais. E o ponto crucial nisso tudo, sem dúvida, é o incentivo permanente para melhorar a comunicação e o comportamento. A questão hoje é muito comportamental. É o médico, a enfermeira, a equipe de saúde saber dialogar, saber ouvir, se colocar no lugar da paciente, da família, do casal, buscando entender as demandas e buscando também orientar com segurança. Eu acho que isto é o programa de consciência obstétrica. É diálogo sob uma forma muito clara, comunicação efetiva. Esse é o manual, né? O Guia de Orientações para o Grupo de Consciência Obstétrica, que abrange os principais tópicos e dúvidas que os casais têm ligados à assistência ao parto, à internação obstétrica. Alguns pontos assim que nós devemos sempre lembrar que nessa trajetória, né, do trabalho de parto, no trabalho de parto, o colo fino, esvaecido, vai dilatar 10 centímetros e o bebê vai transpor a bacia óssea, que tem 10 centímetros. Então, é um trajeto longo, né, para nascer. É os longos 10 centímetros do canal de parto. Uma questão que tivemos uma certa, né, mudança aqui é ver coroar. Eu acho que posicionar a paciente, a parturiente, no segundo período do parto, no momento adequado, fazer o puxo quando pertinente, quando necessário, não posicionar a paciente muito precocemente, isso vai cansá-la, só vai levá-la à exaustão. Eu acho que reaprendermos a entender o que é o coroar. Eu acho que é uma geração de médicos que não fez esse treinamento mais, porque se fazia muito fórceps de alívio, muita episiotomia. E hoje essa mudança de paradigmas, né? A mudança de paradigmas, não são coisas novas, são apenas mudanças de paradigmas. Né? Então, aqui é necessário retreinar a equipe, as enfermeiras, os médicos. Né? Então, esse é um detalhe que realmente é trabalhoso e é um trabalho do dia a dia, essa orientação. Assim como a questão aqui do desprendimento após a rotação externa, né? Desprendimento do polo cefálico, rotação externa, liberação do ombro anterior, que é o clássico, mas se nós quisermos diminuir as lacerações, recomenda-se liberar primeiro o ombro posterior. Isso é um treinamento também, exige um treinamento, exige uma paciência. Este slide, esse diapositivo aqui, é de um livro de 1935. Então, está lá o capítulo dizendo, né, formas de se evitar lacerações. Desprendimento do ombro posterior primeiro. E o diâmetro que é desprendido é o diâmetro cervicoacromial e não o bisacromial. Então, acaba facilitando, o diâmetro que sai é menor, com menor risco de laceração. Isto foi esquecido porque em 1920 se começou a fazer muita episiotomia nas primigestas, né? E se criou um paradigma de analgesia, fórceps de alívio e episiotomia. 1920. Então, este ano, faz um século, né, que o Dr. Joseph Oliver Belli colocou esse paradigma que foi adotado em uma parte do mundo, na América do Norte, Central, América do Sul, pouco na Europa, pouco no Reino Unido, mas são situações que deixaram, por exemplo, essa questão de lado. Então, é algo que tem que ser relembrado. E o Centro de Simulação Realística, ela contribui de uma forma inequívoca nesse treinamento, porque se coloca situações de parto, né, situações de parto complicado, né, que reais, né, com simuladores, com atores, né, colocando realmente o cenário, que a interação é total. Né, e eu acho que isso é um treinamento que foi feito para toda a equipe, enfermeiras e obstetras, né, da equipe interna do Santa Joana. Eu acho que é um momento realmente muito intenso. Eu acho que as equipes acolheram muito esse treinamento. Os médicos externos, inclusive, pedem, né, para participar desse treinamento. Então, isto nos orgulha, né, de algo que nós podemos ainda melhorar, e vamos melhorar mais ainda. Nos outros 4 congressos, né, de medicina obstétrica, nós tínhamos um pré-congresso ligado à assistência ao parto e simulação realística, com 20 vagas e sempre muito preenchidas e muito elogiadas, né? No qual a interação é perfeita. Este ano, por questões da pandemia, não foi possível essa reunião presencial. Esperamos que no próximo ano a gente possa voltar a essa questão do pré-congresso também. Então, consciência obstétrica, qual é o futuro? O futuro para nós é avaliar e propor alternativas seguras para a assistência do parto e trabalho de parto. Por quê? Porque sabemos que há outras formas de se dar à luz, né? Outras formas de se ter realmente uma satisfação plena, né, a respeito do parto, do nascimento do seu bebê. Eu acho que há vários caminhos que podem ser seguidos para o nascimento seguro, o nascimento que traga realmente uma satisfação para o parturiente, para o casal, para a família e para toda a sociedade. Esse é o grande desafio, o futuro do nosso programa. Terminando, gostaria de deixar aqui uma frase, um pensamento aqui, né, do grande astrônomo, cientista, divulgador aí da ciência, o Carl Sagan, que fala que, diante da vastidão do tempo e da imensidão do universo, é um imenso prazer para mim dividir este planeta e uma época com vocês. Acho que foi muito bom estar aqui nesse congresso, ter dividido esse tempo, né, com pessoas ilustres, né? O Dr. Michael Robson, a Martina, né, nossa realmente a obstetriz aí que abriu os olhos nossos para outros caminhos, doutora Ana Pilar, que conhece a obstetrícia no mundo, e com isso nos abriu também a nossa visão a respeito do parto. Muito obrigado e até o ano que vem, novamente. Here in Brazil, we have now people think that they know about how to deliver the patient, and she came with a lot of plans that she read in the internet. Oh, it's good, I will do this. How we can do with these birth plans that are not safe for the patient and the baby in this collaborative model? What to do about this?
Maybe Martina would like to answer, and then Mike comment about birth plans and how do you deal with them in your maternity?
You know, Mario, that's not only a problem for you, it's also a problem for us. We would, first things first, is we would encourage women who have preferences for their birth to discuss them in the antenatal period. Because sometimes women can think actually that, you know, you want to make it difficult for them, and sometimes what they recommend or what they request in their birth plan is in line with what your guidance is for care and labour. So it's about, you know, first of all, making them understand that you're on their side. So for example, a woman who hasn't had a baby before, she tends to have a birth plan based on what she's read on the internet, what she likes to believe is right for her. And the more birth plans you read, the more you realize a lot of them tend to be the same. For example, you know, I would like delayed cord clamping. Well, that's routine practice. So the woman knows now that that's what we do routinely. Or another common one, really common, is I don't want to have an episiotomy. Well, we don't want to have to do an episiotomy. That would, you know, almost encourage the discussion about routine practice and why one is necessary. And I suppose what's really important is you have to be clear about what kind of care you give to women. Like, for example, even another example is a woman who has had a previous cesarean section, and we will often get the question, I don't want to have continuous fetal monitoring. And we all know that continuous fetal monitoring is recommended. If you've somebody with a previous cesarean section, it's recommended that they have continuous fetal monitoring in labour. So we work around that. You know, we say we have telemetry monitors now, and you have to, you know, encourage a discussion. Why do you not want continuous fetal monitoring? Often a woman will say, I don't want my movement to be restricted. Well, we have telemetry monitors, so we can facilitate continuous fetal monitoring, but you still have the liberty to move. So it just encourages a conversation. The other difficulty with that is it's very time consuming. There has to be someone who can sit down with a woman antenatally and discuss the birth plan. But I think when we had an increase in the amount of women that were had many requests in labour, we put signs in our antenatal clinic and around the hospital saying to women, you know, you don't have to write a birth plan, because a lot of these things can be almost, you know, fashionable and trendy, and that's what, you know, write your birth plan. And as we all know, those in clinical practice, if you write a birth plan, you're most likely to be disappointed in the end, because birth plans don't always go according to plan. But if you have a discussion antenatally, often, you know, a woman can minimize her birth plan. And it's about negotiation, which is 90% of what we do. We negotiate with each other, we negotiate with women on a daily basis, and we discuss and we come together and we reach a common ground. And often if you have that discussion antenatally, labour is not the time to be having it. It's too stressful for the patient, for the partner, and for the midwife. So we have huge emphasis that if you have a birth plan, that they are discussed in the antenatal period. And women should be encouraged to go to your antenatal classes so that they have a feeling of what kind of care you are offering them, what your practices are, and they can base their preferences on that. So it isn't just about dealing with the birth plan in labour. It begins way at the beginning in the antenatal period, so as that they're well prepared when they come in labour. Mike, have you anything? I'm sure you have something you'd like to add.
Yeah, no, I put the slide down because it's got an important part in this discussion. I think the first thing to say is, although I didn't emphasize it, but the woman is part of the team as well, or certainly not maybe part of the team, but part of reaching what we want to achieve for the woman. And that's why it's so important. I mean, I think the video that Anne showed, it does highlight some of the issues, not so much why they're good at it, but maybe why we're not so good at it. They have one aim, is to get the wheels on and off as quickly as possible. And sometimes in labor and delivery, our aims between the woman and us are sadly not always aligned in terms of safety, at least, and certain other issues. So I think it's really important to identify this and collaboratively amongst us, first of all, see how we can deal with this issue. As Martina said, birth plans may be just fashionable, or they become a vogue. So people write these birth plans only because they think they're supposed to have a birth plan. And what I try and say to people, certainly when these come up, is I say, just because you haven't got a written birth plan and you've gone to antenatal classes and you're happy with everything, you haven't quite decided what will happen on the day, you still have a birth plan. And it's important to recognize that. So you don't actually have to put something down in writing. I also explained to them about episiotomies or anything else. It's very difficult to put something down objectively. And unfortunately, I think the only way is to be honest with your patients and to kind of explain that to them. Martina said, we don't want to do an episiotomy. But the problem is if you've got, I don't want an episiotomy written on your birth plan, and the midwife, because she's got to know you, never mind whether she knew before, but really likes you, or the person looking after you, and because they want to be nice to that person and give them what they want, and they don't have an episiotomy and have a 3rd-degree tear, the issue then becomes, whose responsibility is it? And the woman will say, well, I said I didn't want one, but I didn't say you couldn't do an episiotomy if it was going to provide. And remember, in all of this, we've got to look after women and their babies, the husbands, the family, but we've also got to look after staff as well. And I think the bigger objective, if something like this comes up, and one that we've discussed, not necessarily always agreed on, is 2 issues. Is I actually say to people, look, the birth plan is, we want what's best for you and your baby. That's our birth plan. The detail, unfortunately, we can't tell. We can't tell whether it's going to be a vaginal birth or indeed a cesarean section. And to kind of focus on particular outcomes at that stage is very difficult. The other thing I think undoubtedly that's going to happen is that we as a unit, whoever that is, and it doesn't mean to say what's right or wrong, we have to decide, we have to look at all the facts, evidence, get something that's simple and consistent and say, this is what we feel is the best for you. But we realize that some people are a little bit, so if somebody comes in our unit, we advise rupturing the membranes to look at the liquor. That's what we've agreed and advised. But if a woman doesn't want her membranes ruptured and there's a sensible discussion about it, I'm not going to sue the woman or make her feel less if she doesn't want them ruptured. But I do think it has to be recorded that that decision was made on behalf of the woman. And if you like to take that particular discussion further, most people would agree that if there was meconium, you would monitor the baby, but unless the woman knows that you can't tell there's meconium until you rupture the membranes, it can't be identified. So there's certain examples where it isn't so important that you're deviating from what your general philosophy is, but there are some, like Martina said again, about previous scars who absolutely refuse to have fetal monitoring. You have a responsibility for the baby as well as the mother. Now, how far you go down that, I don't know. And there are very rarely some people who just don't want any advice at all. They're not very common. They're quite rare. Yeah. And look, sadly, in that situation, I think honesty has to take place. And maybe we're not the best place for them to have their babies. It's just that difficult sometimes. But the point about the slide was to show an example where there could be a challenge, and that however you solve it, either easily or moderately, you have to do it together. Midwives and obstetricians in particular, I think, obviously neonatologists come into it, anesthetists come into it in terms of certain situations about pain relief, but you have to get some agreement, and you have to do it on the basis of honesty, integrity, empathy, understanding, and to a certain extent, you know, some situations are slightly different to others. But if you don't have what you believe is right, and you end up with a woman coming in and somebody having whatever you want today, that's neither safe nor helps working together. Now, Anna mentioned 3 different models of midwifery and care and integrated care. The problem is when you have standalone units, as Anna said herself, they are independent. That's the problem, that they are independent and we don't see each other, we don't work together, we don't understand that possibly some issues like dystocia could have been at least advised, if not managed differently earlier on. But there lies the challenge. Look, I've said enough.
Anna, would you like to comment anything regarding birth plans or women's, your mic is off, women's autonomy? No? Your mic is off.
Sorry. I think Tina and Mike have mentioned, absolutely, from the clinical perspective, said all the important features. So no, I have nothing else to add.
Like I just like to add, you know, women expect now in the modern world to come in and they expect to be safe. You know, they expect that you'll provide a quality service. But their experience is really important for them now. And that's probably a little bit of what our challenge is. You know, they think that they can control, you know, I don't want to be induced, I don't want this. And that's what makes it very difficult, because sometimes we are advocating, you know, unpopular decisions. You know, we are sometimes making suggestions that is against what they would appreciate as being a satisfactory experience. And that's our challenge. It's a real challenge. Birth plans are a real challenge, and preferences of women are a challenge every single day in the life of a labour ward, for certain.
Just a comment, I think it's again about communication, which Anna Pilar showed is one of the pillars of collaborative model of care. So we have to learn to communicate with each other and with women. And it has also to do with learning, because you can teach, I think, younger staff, midwives, younger doctors, how to communicate and negotiate with a woman who wants something that may not be recommended for her in terms of safety. If we don't know how to communicate naturally, and many of us in the healthcare profession do not, we can learn just as we learn how to do a forceps or how to control postpartum hemorrhage. We can be taught skills about how to talk to women, how to reach a common ground, how to negotiate, and how they can be made felt like they are valued, and they're not an object, they're a person, they have rights, they have preferences, and we respect that up to the limit of safety. But there are ways of doing that in a more efficient way in terms of communication, and ways that are completely inefficient, and many of us in the healthcare profession have not learned, I think, at least from my perspective, how to communicate efficiently and respectfully with the women and with each other also.
And I think, Regina, you're absolutely correct, but I think Anna produced in one of her slides, it was like barriers to the outcome, and like often the beliefs of the midwife can influence the decisions that you make, and the beliefs of, like, you know, like we work in a unit whereby we use oxytocin and we actively manage our labours, and there are midwives who maybe come from another organisation who don't believe that that's right. So their decision making can be influenced by the belief, and their belief then is passed on to the woman. And it's, you know, sometimes very difficult if you're taking over care of someone in that situation whereby the care that's been given hasn't been in keeping with your beliefs. So like that's problems we have amongst each other and amongst staff, and about how it's about that goes back to consistency of care, and that is a challenge, you know, there's no question about that.
Can I just say something about communication? I think communication has, for as long as I can remember, has been again and again and again emphasized. And correct me if I'm wrong, but it continues to be. It's as if we haven't tried to improve our communication. And when something like that happens, you just have to look at other reasons. I think there are absolutely examples, be they obstetrician or midwife or healthcare workers, where they really have not actually understood that they're not communicating well and have no insight, and we know, and we can see all of those very clearly. But communication, in my mind, is a two-way process. It's not only the person that's communicating, but it's the person that's listening as well. I often have patients who come to me, patients have often come to me and said, thank you so much for looking after me. You were so good and you explained things so carefully or whatever. And I stop them and I say, look, this is nothing to do with me. The way you are, you got the very best out of me if that's what you feel. And it was often down to them. Unfortunately, there are some people that come in already very scared, have got information that is actually wrong, and they are actually really worried. They're so worried that we can't really put ourselves into their position. And therefore, it becomes very difficult to gain their trust and get their confidence. And really, again, this all comes down to having information and having information about what's likely to happen and data collection, both, as Martina said, not only physical outcomes, but also emotional outcomes, to actually realize how important one-to-one care is. And I'll follow that up by everything else you do to ensure one-to-one care. I again would like to emphasize this issue about prolonged labor. People do not, or they ignore the fact that the longer a labor is, and certainly without any advantages, let us say, with cesarean section outcome, prevents one-to-one care. Because however many midwives you've got, the longer a labor is, the longer a decision is being made or whatever, the more likely you are having women in the labor ward in labor without anybody looking after them, which I think is the most important thing that you can offer to a woman in labor, that one-to-one care. And again, you know, for people to say cesarean sections are more expensive, they just don't understand labor and delivery. I mean, to absolutely promise and deliver on having one-to-one care when you come in and labor, rather than aspiring to it or say it's cheaper, is just, you know, not true. It's really, really expensive to have that, and people don't recognize it. Cesarean sections, you know, you can line them all up one after another and do them. And I, in my view, don't think they're necessarily cheap. And I think it's one of the weakest arguments against that. Providing good labor and delivery care is expensive, and it takes a lot of time to think about it. The other thing about teamwork is that when a woman comes in, how we are seen to negotiate, to talk between ourselves is so important. I didn't emphasize it, I forgot to emphasize it, but they suddenly believe in that. So that kind of interaction between staff and smile and reassure is so important and can't be emphasized. And just seeing that, I think, helps people.
I have another question related also about education of women and the importance of talking to them before they come into the labor and delivery ward, which is during antenatal care. I mean, collaborative model of care can also work, as we've seen, and WHO has carried out randomized trials about that before the woman comes into labor. Like antenatal care can be given also by midwives, nurses, and doctors working collaboratively. And that would probably prepare the woman better for when she comes into labor, into a hospital that provides a collaborative model of care during labor. So maybe you can comment on that. What's the role of the midwife or nurses in Ireland and in other countries? Maybe I can talk about that too, during the antenatal care period, and how does that integrate into the collaborative model of care? The antenatal collaborative model of care and the intrapartum collaborative model of care. In my view, that would be the ideal world, but we're far from that here in Brazil or in many other countries in the world. So I would like to have your point of view and opinions about that. Maybe starting with Ana Pilar from the international perspective. How does that kind of care start before the woman arrives in labor in the hospital?
Thank you, Regina, for the question. I think, again, from the international, from the global perspective, this is a very broad and challenging issue, particularly from the low and middle income perspective in which there is, in which the burden of the different actors on antenatal care and the intrapartum care is already very heavy. From the perspective also of the logistics, that there are, in many places, antenatal care is not even provided nearby where, the hospitals or the facilities where the women give birth. And also, as both Tina and Mike have emphasized, there is no consistency of care. There are no principles, there are not cohesive care. So ideally, models of care that ensure continuous care from midwife in the case of low risk women or women without any pregnancy complications are ideal, but the challenges for implementation are, if they are difficult in high income countries, the challenges for implementation in low and middle income countries is just enormous.
And I suppose, from our perspective, we would feel that antenatally a midwife has a huge part to play in the midwife in antenatal education, in preparation of the woman for labour, because every woman has a role to play when it comes to labour. She has to understand what is expected of her, as well as what to expect when she comes in labour. And, by giving her this information, you'll dispel any fears that she may have, or that would be your intention, or it may reveal to you fears that she may have that can be discussed antenatally. But I think it's important that, and I know Anna talks about the lower income countries, and they don't have this privilege really of having a midwife that perhaps can be part of labour and delivery ward. Like, if you have antenatal care provided by a midwife, they've got to know what goes on in the unit where the woman is going to deliver. They've got to know the practice standards. They've got to know what to expect for this women. Ideally, they've got to know the outcomes of the unit. So if you're educating a woman on, say, who's had a previous instrumental delivery on a first baby and she doesn't want to have another one, the antenatal midwife who's providing the education has got to know what the expected outcomes for a multip who's had a previous operative vaginal delivery. I mean, that's, in the ideal world, they've got to be part of the staff. They've got to know what goes on. And we're even challenged with that in our own unit. We sometimes feel that there's a little bit of a disconnect from the midwives in the hospital who give the antenatal education and the midwives then who provide the care on the ground. I know my midwives in the labour ward would feel the time has come whereby they really need to be actually giving the classes about, particularly the portion about care in labour. They feel, as midwives working in the labour ward, that they are best served, because they really feel that the responsibility on the mother to be better prepared for labour, they feel they get that message across. So, I mean, even in a country that has a well set up antenatal education program, it's by no means ideal. It's by no means. There are loads of ways in which we can improve, let alone having the geographical challenges that lower income countries would have, where women don't have any antenatal care, let alone antenatal education. I can't imagine what that's like.
Can I ask Anna? I mean, in the low-income countries all over the world, I mean, and you know more about this than me. I mean, there are obviously some very big shortcomings in very basic care, but things like one-to-one care and, say, for example, antenatal classes, what are the barriers that are stopping those two things? I mean, just in very simple terms. I think sometimes we try to kind of prove that things are evidence-based and they make a difference, when, you know, it's common sense, surely, that having somebody with you in labor and providing information for you before you go into labor is just, you know, should be available. I mean, is it a resource issue? Is it an education issue? Is it a philosophy issue?
It's all issues together, Mike. For example, for the antenatal care education, you can see, and I'm sure you've seen, for the antenatal care in many low and middle income countries. Obviously, I'm not considering the private hospitals or the private sector. Women, you can imagine women coming at 7 or 6 o'clock in the morning to the antenatal care clinic. All women, not just at your appointment. There's no appointments. Antenatal care is from 7 o'clock to 12 o'clock, and everybody comes there. So you have at the door of this antenatal care clinic, maybe 70, 80 women just waiting for their antenatal care consultation. So education takes care, and I'm giving just one example. I'm not saying everybody's like that or every place is like that, but so you have education for antenatal care happens not in one-on-one, but in 100-to-1. So one midwife is just, gets out in this waiting space with the 50, 60, or 70 women that have showed up there for the day, and give some information about what they could expect or whatever, is relevant or has been
verbally or in writing or verbally?
No, verbally. They also may distribute, tubes for, having a urine analysis, right there in the middle. So again, there are many things that you can learn through this, and you may think is better than nothing, but nothing to do with asking, having a one-on-one personal consultation to ask your very dear fears facing labor. So, for example, and then on the one-to-one during intrapartum care, it's just the same. Sorry.
To one in labor,
in labor,
what are the barriers there?
Same, human resources, and you may have one nurse to attend all these 50 women, and I'm not saying it's just one, but it's definitely an under-resourced moment. And then women are put all together to labor, and just when they are about to give birth, they stand up and they come to another room where there may be a nurse just is putting all the effort on her to the last push.
Yeah. But do we know anything about the length of labor and how long they are in labor, or nothing about that at all? Just that there aren't enough staff.
Yeah. And also, Mike, women, you are assuming from your experience in high-income countries that women, as soon as they feel they are getting into labor, they come to the hospital. In some countries, women just avoid hospitals for as long as they can. And this is the reason for a lot of second stage cesarean sections and dangerous cesarean section, because it's just, when a woman, has no choice because, is fearing death, that's when they approach to the hospital or to the facility.
And is that, and is that our fault or their fault? Are they encouraged to attend hospital earlier, or are they encouraged to wait at home as late as possible? Because we certainly have many people encouraging women to stay at home for as long as possible.
I think that the causes vary between countries and between facilities, and that you may have places in which doctors and the health systems encourage. And I think more and more, like I said in my slides in the very beginning, in one decade, there has been a huge increase in bringing women to give birth in the facility. But there are other places where, like you were saying too, the quality of care is not, good. So women just are, women make the choice, as you said, of not going to the facility, not because they don't want to, it's just because they want to avoid what's happening if they get there. Again, I'm not saying the whole world is like that. I am saying certainly there are places like this, and they have a whole different dimension of problems and challenges than the ones from the National Maternity Hospital, which I think yours are relevant here, in talking with Santa Joana Hospital and the challenges that Santa Joana Hospital may have. Their challenges are closer to your challenges than to the challenges of other countries in Africa. So.
Oh yeah, I think you're
right. Dr. Makoto, anything else you'd like to comment or ask before we finalize the session?
Okay, I would like to say, correct me, I am wrong, but I think that our challenge now is to have a collaborative model with nurses, midwives, doctors, and all the people that works in our hospital, because this thinking, this knowledge that we do a good assistance in normal vaginal delivery it is essential to change the minds. Okay, our people knows that we do a good C-section. We are specialists. Now we will do a vaginal delivery with safety for the mother and baby. Everybody in our hospital must know about this. This is the challenge. Communication, that's the problem, the communication, the collaboration with everybody, and the training. I think that's the training. It will be the great challenge that we have to train, to communicate, because this Portuguese language, it's a good language, but sometimes it's difficult to say. I think that I was clear in my speech, but it was not, because the other can understand completely different that I was thinking about. And so it will be a good desafio, sorry, Regina, desafio, challenge, good challenge. I hope that this Congress, it will be the beginning of the collaborative model in our group. It will. We hope that we are initiating a new model with the collaboration with Dr. Michael Robson, Martina, Ana Pilar. It will be a great job. Thank you for the opportunity to have with you.
Thank you very much.
Thank you. Thanks for that, Mara.
Okay, thank you very much.
I'm sure it will be.
Thank you, everybody.
See you next year live.
Yes, live. Good idea, Anna.